Good morning and good afternoon to everybody who has joined us for this webinar on managing medical emergencies across the globe. My name is Wendy Green, and I am the director of iJet University. I just wanted to take a moment to do a little housekeeping up front. You see that you can join the call by dialing in, or you can use the speakers and microphone on your laptop or desktop. Everybody who joins the call joins as muted because we have so many people that have signed up for this call. We really are not going to be able to handle all of the interaction verbally. However, your questions are going to be very important to us, and both of our presenters look forward to be able to interact with you and answer your questions. So please, if something comes up for you, type it into the chat box, type it into the questions box. I will be monitoring that, and I will be able to ask your questions at the end of the call. I want to take a brief moment to introduce you to our two presenters. We have some exemplary speakers on the phone today. John Rose is the Chief Operating Officer at iJet International, and John is co-chairman of the Global Business Travel Association Risk Management Committee. He's active in the GBTA Foundation, RIMS, ERMIA, and was honored at the Baltimore Smart CEO organization. We also have Dr. Kai Gluszak. Dr. Gluszak is the International Medical Director and Chief Medical Officer of AXA Assistance and AXA Travel Insurance. He has provided medical direction for travel and corporate assistance for 17 plus years and currently has a team of more than 20 medical directors and 300 medical staff throughout all offices of AXA Assistance globally. So with that, I'm going to turn this over to John Rose to kick us off. John?
Great. Well, welcome everyone. Obviously, this is a very important subject, and we want to dive into it right away, and then hopefully everyone will pick up a few things of interest today, and please start documenting your questions because we've got plenty of time at the end where myself and Dr. Gluszak will be able to address your questions and go forward accordingly. So a few things we want to talk about within why are a medical officer and a security company talking about this. Well, there's actually two components to health and medical, and we want to address both of them. First off, just to start off with, we're an integrated solution because often a medical or a health situation can happen, and there could be a security component to it. Let's take the horrible incident in Brussels yesterday. There were medical emergencies, but it was obviously a high security situation. Well, that's not that uncommon in many places in the world where someone can be hurt, but if they're injured because of a security situation, whether it's a terrorist situation, which is fairly rare, but it could be more prevalent that it's a violent crime, and those entities have to work together. Now, there's a few things I'm going to touch on here on the list. One, I want to start off with the duty of care component. Duty of care gets a lot of attention, especially in Europe, because it's actually law there. In the U.S., it's a gray area, but of course in the U.S. market, one thing that isn't a gray area is anything can be litigated. And one thing that employers are very fearful of is employee lawsuits against their institution. Now, very rarely do those go to court. Generally, those are settled out of court because the employee almost always wins. Is the reality of the world. So companies tend to settle those. Well, what the duty of care, if you want to think about it in the simplest format, is what do other companies that are similar into the way you do business do for their employees? And where most companies make the biggest error is they fail to take care of the employee when they're not working in one of their facilities, but they're on an assignment, and an assignment can be as simple as a one-day business trip. So what that means is if you have sent that individual to a location, they are there paid for by the company under direction of the company. This isn't a vacation, a personal choice. So if you don't take care of them the entire time, and that means provide them the proper access to safety and security, then you are in a duty of care violation. And the way to think about it is you're not going to send someone to a city and put them in the most dangerous part of the city in an unknown hotel or an Airbnb property that's in a dangerous location. You would like to say you would never do that. Companies do it all the time because they don't know any better. They don't do any type of preparation work. If you send someone to an international location and they've got no medical coverage, because their medical insurance offered through your company may not cover them at all, and Dr. Glushak will get into that in more detail later, then you are in a duty of care violation, and you're going to have to write a check, which Dr. Glushak will get into what that could mean financially for your institution. So the duty of care is taking care of the individuals while they're outside of the home office, just like you would in the home office. In the home office, you've got security, you may have guards, you may have access control, you've got lit parking lots, proper elevators, but you send them to another location and you don't know if any of that is covered, but yet the employee feels that their safety was in jeopardy. So that's duty of care in a nutshell. Another thing individuals need when they're traveling is a trip brief. They need to know where they're going and all the information they need about that destination, because everything is different than their home location. Prescription medicines may be completely illegal in that country, and I'll let Dr. Glushak get into that, but in countries we deem extraordinarily safe and Western friendly like Japan, you go to jail if you bring in certain prescriptions that are legal for you to have in the United States or Europe, you can't have in Japan or the UAE. That's criminal. So you have to understand these things in a trip brief standpoint. You have to understand the access to medical facilities, because if you've got a medical condition that you may require treatment and you're going to a location, it may require you to go to an entirely different continent just to get treated for that condition. And you need to be aware of all of this ahead of time. Health alerts. I want to clarify the difference between intelligence and medical information. Medical information is what individuals like Dr. Glushak can give you on this is what you need for your particular medical situation. Health alerts are intelligence, saying this is the impact of a health situation that's going to create a potential threat. Zika virus. Okay, if a country is combating Zika virus and their national resources are being spent combating Zika virus, does that mean if your employee or traveler, I don't want to pigeonhole this to employees, your personnel that are in motion, does that mean they can't even get proper treatment at a hospital for the flu because all the resources are being dedicated to fighting Zika or fighting Ebola or fighting whatever disease that region is being impacted with? You have to understand the intelligence implications of what that could mean from a disruption standpoint. And medical situations can often escalate to where it now becomes a national security issue. In the case you saw that with Ebola, you're seeing it with Zika. There are people even questioning should the Olympics happen in Brazil over Zika. Now, I'm not going to make a political statement whether it's good or bad. That discussion has happened, and it's a realistic scenario, and Brazil's going to have to spend billions combating this just to make their games a success. So that's the difference in intelligence versus medical information. Intelligence isn't going to tell you how to treat Zika that moment that you contracted it. That's where the medical situation comes in. Okay, next up is vaccinations and health threats. You have to understand what vaccinations you may need to go to that country. You may be going to a malaria zone and you need to take appropriate malaria meds as prescribed by a medical professional. You may have other health threats that are potential in that region, just as simple as catching Zika. The employees have to know that. If you've got a female traveler and you're sending her to a Zika zone, that may be seen to her as unacceptable because of the potential threats of birth defects. So the employer has to be very, very conscious of this and who they're allowing, because it can be spread, sexually transmitted. You have to worry about males going into the zone because it can implicate their entire family and put them at risk. So all of this factors into it. And then the last thing on this slide is insurance. You need to know if your insurance covers those travelers while they're abroad. What is covered and what isn't covered. Okay, if you don't have security evacuation coverage, fine. But if that's $500,000, who's going to write that check? The employee's not, because they're there on the company ticket. You put them there. Medical. Well, their medical insurance may or may not cover them, and Dr. Glushek's going to get into this, but you need to know the implications of your insurance. So that covers everything on this list, and a couple of other quick notes over to the side. You know, of every 100,000 travelers, 50,000 will experience some health problem. Now, most that's gastrointestinal discomfort, but you have to think about it. Those of you in your home office today, if your stomach's upset, you're probably not going to think twice about it, or if anything else, you just eat a little differently today. If you're in New Delhi or in Bangladesh or in Cairo and your stomach's upset, that traveler now goes into a bit of a panic mode, because they're thinking, what if this is something much, much worse than just, I don't feel so good? What if this is really bad food poisoning, potentially life-threatening situations? And that goes through their mind because of the access to health care and the real and perceived stories they've heard about individuals getting food poisoning or waterborne illness while they're traveling. So that's a real issue. And then 8,000 out of every 100,000 is going to need to be seen by a doctor like Dr. Glushek. Well, that's extraordinarily high. Think about that. That's not a random situation where a lot of individuals say, well, I'm really not going to buy all this additional terrorism coverage because I don't think my employees really have a risk of getting hit by a terrorist. That's a different discussion to have, where it's 1 in 10 million. Well, 8,000 out of every 100,000, well, okay, if 8% of your business, that says 8 out of every 100 of your business travelers are going to have to see a doctor. That's a lot. Now you need to address it. 300 will have to go to a hospital. Again, it drops down quite a bit lower, but that's still a significant percentage. Only 50 require air evacuation, but let me tell you, when they require air evacuation, it's severe. Now it goes all the way up to where it's an air ambulance and a cardiac patient, but that's a lot. And then 1 out of every 100,000 will perish during the trip, and that's obviously a very low percentage, and we'd like to see that continually lowering, because of proper preparation, the risk's lower and you don't have as many fatalities. Okay, next slide, Wendy. Okay, now you have to think about the cost to your organization. Best practices have proven that if a care manager is involved early in the healthcare condition and advocating for the patient, your individual you sent there, it can result in better healthcare outcomes and decrease in amount of money spent. Okay, so there's two major takeaways there. The faster they act with a proper medical professional, the higher chance of the situation not ending up with a horrible result all the way up to death, and the lower the cost. So it's absolutely paramount that you have access to the medical professional, and it's fast, because it's also going to save your company money. And we don't want to get into this argument about, well, we want to save money before you treat the individual. These go hand in hand. The faster you act, the cheaper it's going to be. So there's absolutely no reason to delay action, because the average medical evacuation cost is $25,000 to $250,000. Highest I've ever seen is $1.71 million. And that entity did not have insurance on it. The chief financial officer had to wire money to handle that situation. It was in Turkey is where it happened. So those situations are real, from real providers. If you don't have that coverage, somebody's going to have to write those checks. And I'll let Dr. Glushek get into the details about a lot of countries you have to advance pay. You can't, even if an employee has their own medical coverage, can you expect your employee to come up with $43,000 to be admitted to a hospital to be treated? Most people don't have that kind of available credit, and even if they did, do they have a way they can actually pay for that in an emergency situation, or is somebody else going to do a guarantee of payment for them? So it's extremely important that organizations understand the financial risk of a medical situation, because as we just talked about, 8% of your travelers are going to have to see a doctor. Okay, that's the reality of real. Those aren't statistics from IJET or AXA. Those are industry statistics, either from health boards, and the very similar one that the Global Business Travel Association ran. Those numbers tie out the same. So those are real scenarios of what's going to happen. And now, like right on cue here at 9:15, I wanted to turn it over to Dr. Glushek and let him get into the meat of the medical situations. Thank you.
Hello, everyone. So taking off from where John just finished, he was telling you pretty much about the threats and the risks, as well as some of the preventive measures you can do prior to travel, planning, and getting everything in order before you go. I'm going to concentrate a little more about what it's like once you're into the situation, but much of it will clearly tie back to what preparations you made or could have made or your employee could have made prior to traveling to mitigate the kinds of things I'm describing. And the reason I have to do this is because it's very hard for both management, HR personnel, and even the individual traveling to imagine the kind of things we find ourselves taking care of every day, the kinds of emergencies, both minor and serious, that they may well encounter. They're almost unimaginable sometimes to people who have not had to deal with them. And it's not to over-dramatize it, but some percentage of your traveling population will get into these situations. And when it is, all efforts are focused on them. So just to give you a sense of the kinds of things that we deal with, the reason to prepare the individual and the organization, it's not just a matter of gathering health intelligence, which is clearly important, looking at the CDC travel site or wherever else you get your vaccine recommendations and that kind of thing. But it also involves the value of preparing for an individual's personal risk. So if you've got an executive traveling to one of the industrial sites who has high blood pressure and has had a cardiac bypass and takes certain medications, that person doesn't have the same risk and exposure when they're out in the field as the 25-year-old intern who has no medical problems at all, who's just completed a few years back his series of childhood vaccinations, hopefully has gotten any additional vaccinations he needs, and is ready and raring to go and jumping out into the field, and is probably not going to run into any spontaneous health problems other than accidents or some of the maybe unusual diseases one encounters when you're overseas, which I'll talk about in a little bit. But the getting up in age executive who's going to make the rounds of the site visits, who's dealt with a number of medical conditions, is clearly more at risk. And having a very individualized approach before leaving is really important. And I think you all know the type of individual. We do so much travel in our corporate lives typically that you don't think about buying that plane ticket, getting to where you have to go, and you're focused on work. You skip this aspect of it, you can well imagine the kind of problems you're going to run into when you have, oh my God, I'm feeling that chest discomfort that that I had about 3 months ago. I never got a chance to go see my doctor about it, but I know I have this heart problem. Oof, I didn't even think about it. So now the question with that is specifically determining the kind of medical services and resources and preparation and information you're going to need to avail yourself of these things before you go. If you're going to Nigeria to check on the oil refinery or the oil drilling areas in that area, and you have seizure disorder, you have an underlying cardiac disorder, you have diabetes, don't you want to know who you can turn to if you get there and find out, hey, I may have to see somebody if something goes awry with my sugar control, if I have some difficulty refilling my medications, whatever the issue may be. But don't you want to know, first of all, that your medical situation, your medical condition has been optimized before you travel to a risky location like that. And then if I do get there, and God forbid have a problem, where do I turn to? What resource should I count? Or I recognize the fact there won't be a very good resource. What will be my mitigation plan in case something crops up? How will I get to the right level of care? So all of those things are really key. And one of the things you can do, and we can fill that role if it's needed, is to offer to traveling members of your organization a personalized assessment prior to travel to really size up what that risk is and get them very specifically prepared to meet any risks that are tied to their personal medical situation. I will say John doesn't exaggerate. We are always facing issues of evacuation, and the range of costs are enormous, and people are always blown away, have no idea how much medical transportation costs. The more remote you are, the more difficult you are to access, generally speaking, the more costly the medical transportation will be, because you have a paucity of providers serving those areas, and to get them in there is expensive, and they charge more because they know there aren't a lot of resources to turn to. The kinds of other challenges you face, I don't think you need me to go into. How do you manage a heart attack? How do you manage a stroke in these areas? Medical problems are medical problems. What I find we are dealing with more that's very specific to handling medical emergencies abroad is really the logistics issues that comes into play. John mentioned making sure appropriate coverage is in order. So obviously, you want to know you have the ability to pay for your care. But why is it really that relevant? If you're thinking, hey, if I have an emergency, I'll find my way to a provider who will at least start to take care of me, and we'll deal with the financial issues at some point. Well, the reality is the world doesn't necessarily work like it does in some of the countries we live in, which have clear laws and clearly enforced laws that require a provider, especially a hospital, to provide emergency care and not withhold it for payment purposes. In the U.S., those of you from the U.S. know that there's an EMTALA law that absolutely requires hospitals and emergency departments to render emergency care until that medical condition is stabilized, whatever that means. That could mean after 2 weeks in the hospital, or it could mean after 15 minutes that you stop somebody's bleeding. Whatever it is, you have no choice but to render that care, and most providers won't even bring up the question of medical coverage until they can demonstrate that they have provided the emergency care that's needed. In the rest of the world, that doesn't necessarily apply. In parts of Europe, in the US, in Canada, we know those rules are usually pretty consistently applied. But in much of the rest of the world, in developing medical systems, those regulations don't necessarily exist. And literally, a provider in a certain country can simply refuse you access to an emergency room, can eject you from an emergency room, can simply refuse to provide any kind of emergency medical care if you don't show the ability to pay for it. So unfortunately, that becomes a clinical reality, and what you want to do is to have all the measures in place to make sure that demonstration of that payment and even transfer of those funds can take place on a 24/7, 365 basis in order to avoid any kind of treatment like that from a provider. What you don't want is for your employee to show up in one of these places who may well be able to provide very good care, but who will say, how are you going to pay for it? And you know you have good coverage. We all are convinced of that. The problem is we can't confirm the benefits on the spur of the moment, and we can't arrange to transfer any funds if that's what they're demanding. This is where I have clients that I love and other clients that, well, I don't love as much. The ones that I love are the ones who have given us a mechanism so that we can make that benefit determination and ensure that the funds are covered, are available so that we can tell the provider, don't worry, we will pay for your services, and we can make that statement on an emergency basis 24 hours a day, 7 days a week, 365 days a year. And in some way, we have the ability to do that. Now, that could either be because that committed client makes themselves available, has somebody authorized at the client level or the insurance level who we can deal with, who can give us a rapid response, or because, as an assistance company, they have delegated that authority to us, and we don't need to call anybody. Whichever way is fine, but the point is there's somebody available all the time so that we don't have to hold up that decision and potentially hold up the care the patient is getting. So the clients I don't love so much are the ones that kind of operate on a 9 to 5 basis, banker's hours, and say, you know, unfortunately after hours there's nobody who can deal with those decisions. It will just have to wait till the next Monday morning or Tuesday if Monday's a holiday, and the patient will have to figure out how to deal with it. We have clients like that, and we unfortunately have to tell certain patients, we'd love to help you, but unless you can pull out your credit card or your checkbook and pay for this in the meantime, you're just going to have to live with whatever the provider there is willing to do. And that has applied both to getting medical care on site, and it has also applied to getting a transportation provider willing to evacuate a patient. So both of those things can be held up if you can't authorize payment at that moment in time. We have had cases in places as with good medical skills, for instance in Brazil, where we've had a patient with a serious cardiac condition admitted to the hospital, but they would not open up the cardiac catheterization lab because this guy needed his arteries looked at and opened up until we were able to definitively prove to them you're going to get paid. And in one case, because we could not get the insurer or the client to make it clear that payment was available, it waited at least 24 hours before the cardiologist and the catheterization team were willing to come in and do the procedure he needed. So we try really to avoid that happening by having some form of delegation or act as the decision maker at all times on an emergency basis. Another thing that comes into play that can be very difficult is the issue of handling key documents, especially the passport. The trap we see patients fall into over and over again is they present themselves for medical care. They are admitted to the hospital. The provider takes it for granted they're going to be paid. And then at the time when you're either ready to repatriate the patient, discharge the patient, or even worse, evacuate the patient, they will not release the patient because they have confiscated his or her medical documents and passport, and the patient doesn't have any way to leave the country, much less the hospital. This happens all the time. And so what we advise travelers is to absolutely not surrender their passport or visas or key documents to the hospital. They should have them in safekeeping with somebody they trust. They can give them copies of it, but the original documents should stay somewhere out of the hands of the provider who may basically keep them hostage with those documents until, generally speaking, they're convinced they're being paid or have actually been paid. So one important thing to always advise travelers, and something that can avoid a great deal of headache and even life threat at times. Finally, I think it's really important that anybody going into planning for managing these emergencies makes sure that the lines of communications between your assistance provider and within your organization are clearly mapped out. Because where we run into difficulties, and especially with corporate situations, you have managers in multiple sites, you have them centrally, you have them on site, you have family back home, sometimes you have family with the patient, and all of these people are getting information at different rates and oftentimes getting different information. You have the assistance provider, sometimes you have a broker involved, and to make sure everybody stays on the same page, and that finally the patient is getting clear messaging and has clear expectations of what can and cannot be done for him or her, is absolutely critical. Things fall apart when different parts of our organization talk to different people and leading to complete confusion around the situation. So get your contact tree carefully organized, coordinate with your assistance company, both your medical assistance and your security assistance company, and stick to it and keep it as organized as possible, and review it at the time of the incident so that you reinforce, okay, who does the speaking to whom, how do we keep the messaging consistent so that in the end we provide a consistent, reliable service consistent with the expectations of both the client and the patient. I'm just going to go through a couple of aspects of the situation here on medical emergency stages that you may or may not be aware of. For one thing, we've talked about emergency response and stabilization. Obviously, you get the person to the best there is locally as the first step. That may not be great care, but that is generally speaking the first step. Then if the patient, if after getting a good medical report and sizing up the situation, it's clear that that will not be adequate to maintain the patient or respond to their needs, you get them to a higher level of care. Many of your employees think that means getting an air ambulance and getting all the way back home, whether that's across an ocean or some other long distance, and that the only place they can get adequate care is at home. That's actually usually the opposite. If they are in such need of acute care, then usually getting all the way back home, unless home is very close, is generally not the safest plan. And we can assure everybody now that in pretty much all quadrants of the world, all hemispheres, north and south, that there are centers of excellence that approach the level of care that are delivered in the best countries, and therefore that approach the level of care that a patient would get back home. Usually it's better to, it's in their medical best interest to get to that regional center of care, get the acute situation under control, and then stage them on to getting home or wherever you want them to eventually end up. Maybe it could even be back to work where they were located before, but to get them back into their more comfortable environment once the acute stage has been fully managed. There are exceptions. It's very rare that you have to truly air ambulance somebody all the way back, say, from Africa to the U.S., or all the way back from Mexico to Europe, or all the way back from Canada to Japan, because usually you get the situation under control somewhere in that region, and then they can be brought home in a more normal fashion. And the rare times that you have to do this kind of thing is when they have really individualized, highly complex medical problems that will not settle down without getting back to the attention of a very specialized center in their home environment. But those are unusual. Those are those are by far the minority of the situation. Once obviously they've been stabilized, we repatriate them according to their needs. They may be able to walk out the door, or they may need some form of medical support, but hopefully the situation has de-escalated, and we've dealt with the issue of coverage of the medical expenses, which plays into this. I want to mention a few special situations that we have to deal with. They're generally crisis-type situations because they're a bit hard to predict until you're in the middle of it. But they don't just affect individuals typically. They infect groups of individuals and maybe affect groups of your employees. And those are the infectious disease outbreak situations, tropical diseases, which you are not normally exposed to in your home countries often, but depending on where you come from, of course, but that may be very different from what you're used to experiencing at home. And these present obviously special challenges that we're typically prepared to deal with, but in which companies typically need special support. So when we have situations like the Zika outbreak and all all of the anxiety that creates, and whether it truly is a crisis and a real threat to your employees or more of a media crisis. Those are the things that both you need to plan for in terms of how to manage your employee population and how you work with us to give you good advice, guide you through it, roll it into your continuity planning, and sort a way through it. And as much as anything else, decrease the anxiety level and the level of panic among your workforce. And this is something we typically work through in all of these outbreaks, be it Zika, Ebola, Lassa fever, any of the other things. But the two aspects of that are how do you support travelers through these things, and then also how do you support the home workforce who often have anxieties about, oh, what do we do now? The employees coming back from one of those areas, are we going to be exposed to the diseases they were exposed to? Oftentimes, that takes a whole course of panic of its own, and it's usually exaggerated. Not always, but usually exaggerated. Tropical diseases typically factors into this. And multiple traumas, if I skip a note here, is another mass multiple victim type of thing that we often have to coordinate, because if you have a traveling group, they may all be involved in, say, the same accident or, God forbid, the same terrorist incident. And so you have to know how to manage multiple victims, how to mobilize special resources, how to maintain appropriate communication through the whole event. I do want to make a special note about rehabilitation. It's important, and it's usually not thought about in advance. But if you think about what happens at home, typically you have a relative who has some serious illness that causes either temporary or long-term disability. Let's say a stroke. So you have somebody who is working and who's 60 years old and suddenly has weakness on their left side of their body, can't swallow fully, and this is not going to recover overnight. If they're lucky, they'll get it back, but if they're like most patients, it will be a somewhat prolonged recovery. And so, generally speaking, in most places where people end up, you'll get the stroke handled just fine. We'll get you through the acute phase. But then the question is, when will they be able to walk out of the hospital and resume their activities or get home? And it's in the rehab phase that we not only have to plan for what's best for the patient, but where much of the risk comes in. What we find is that the patient is stabilized, say, after this stroke, but then they're sitting in a bed. Everybody says, what's the big deal? Give them a week to recover or whatever it's going to be, and then transport them wherever, get them home. But they're sitting in an institution, and this is where many hospitals in developing countries especially fall down. They may have their acute care well organized, but then they go out onto a regular floor and they just sit in a bed. Nobody notices that they're having difficulty swallowing and doesn't work on managing their ability to eat and drink properly. And the next thing you know, that patient, who was completely stable after their moderate stroke, has aspirated on something they've tried to eat and now has a very serious pneumonitis, and it's become actually a very critical case. And so what I think we have to recognize is that even though we often are very successful getting the acute phase of care dealt with wherever they are, even in some developed countries, it's in that lower acuity recovery phase that the complications happen. And so we need to focus on maintaining support of that patient through that phase and avoiding an avoidable poor outcome because they haven't gotten the attention they deserve during the rehabilitation phase. We can move on. So just to give you a couple of interesting case studies, and I chose a couple of examples because we all know about heart attacks and strokes and trauma, head trauma, and the kind of things that you hear about every day. But here's some of the things that happen more frequently than you might think, and that we have to deal with on a fairly frequent basis. We had a patient recently, young adult, who was traveling in Peru, in Cusco, and was bitten by a stray dog. Now, stray dog bites are really common incidents, especially in developing countries, where the dog population is not as well policed. Vaccination can't be counted on in these countries, and you never know whether a dog is healthy or not. And so we assume in all of these countries that a stray dog could be carrying rabies. And the incidence of rabies varies around the world, but is definitely higher in developing countries. And so, whereas the wound itself may be fairly trivial, the prospect of possibly having been infected with rabies is extremely serious. The problem is, and this applies even to travelers who have had rabies vaccination, and very few travelers actually get rabies vaccination before they travel. Even for those who do, if you want to prevent rabies, you have to complete the vaccination series, but even before that, you need to receive rabies immune globulin. Rabies immune globulin is the earliest phase of treatment because it gives you immediate immunity while waiting for the vaccine-induced immunity to develop. And it's considered part of a Western protocol, meaning developed medical systems, so the US, Europe, Australia, Singapore, all of these countries would give rabies immune globulin as the first step of care. It's rarely available in most developing countries, and we know our experience is that throughout Latin America, it may or may not be available, but it's typically very hard to find the location that has it in stock. It's very expensive, so most providers don't stock it. And in this case, we decided to put the patient on a plane. They didn't need much help because they weren't having problems with the wound itself, but it was the only way to get them back to a provider which we knew for sure would be able to administer the rabies immune globulin, which should start within 24 hours ideally, but absolutely must not wait longer than a week to be administered. And so people in this case were asking us, why on earth for this minor bite does somebody have to go all the way back to the States? And it was for this reason, because it's very hard to assure that we'd be able to get them the immune globulin anywhere in Central America, and we didn't want to waste critical time trying to figure that out. So this is the kind of thing you may well experience. We shouldn't have to bring back somebody all the way from Asia or from Africa to do this, but you may have to move them to another area where you know that medication is available. Another interesting and actually quite frequent encounter that we have is when somebody receives an initial diagnosis of cancer during their expatriate or business travel itinerary. We had a patient that was spending time in Argentina, a patient from Japan, who was diagnosed with leukemia. Didn't get extremely sick actually, just had a minor bleeding episode, but then when they did the blood test, they found the blood count was off the wall and made a quick diagnosis of leukemia. They did the initial stabilizing treatment immediately. They had to do chemo, which is called induction, just to get the blood count under control. The patient remained quite stable, but what you run into now is the fact you know this patient is going to be facing a prolonged and intensive course of care with potentially significant complications. And generally speaking, very few patients want to do that when they're so far away from home. They want to get home for the duration of their cancer care. So then it becomes an exquisitely sensitive process of coordination of transportation to safely get them home and get them into an appropriate oncology hospital back at home who's ready to pick up expediently and with the proper timing from where the initial hospital they're treated left off. As you all know, chemotherapy, which is typically involved in most cancer care, the biggest complication of it is some degree of immune suppression. But then there are other complications that occur as well. And if you have to give it according to protocol and according to timing, those protocols cannot be interrupted. And if you reach a point with the chemotherapy that the immune system becomes very depressed, you cannot transport that patient. So think about this, because when you have a patient that presents with this problem, the question is how deep, how far do we go with the cancer treatment that you've been diagnosed so that we don't prevent you from getting back home for the long period of cancer care that you're going to need. And in this case, we really had to orchestrate this extremely quickly, get the benefits and approvals lined up, time the initial induction to control the leukemia, and then arrange for readmission in Japan, which is an arduous process, and the right level of transportation to safely get this person home to Japan so that he could be immediately readmitted and be ready for the course of leukemia treatment that he would have to undergo once he got home. It was done successfully, but it really takes careful coordination. And those are just two of the more complicated but frequent situations that we deal with on a regular basis in assisting patients for medical emergencies.
Okay, well, thank you for that. We did have a request to go to this graphic to look at the statistics that were shown about the travelers and the impact of a health emergency on their trip. So I'll bring that up. And then I do have a few questions for both of you. Let's see. First question, Dr. Glushak, kind of ties into the case studies that you were just going through about the medical evacuations. And the question is it always required that there's some kind of medical evac equipped jet or helicopter type of aircraft when you have to get somebody out of a country back to their home country?
Yeah, that's a really good question. No, it's generally speaking, it's not as dramatic as all that, and actually, we don't advise it in many situations. When you're going a long distance back, usually you're traveling on a Learjet, Lear 36, Lear 35. That's what most of the air ambulance companies use. And just an example, when bringing somebody, say, from Western Africa back to New York, if that's what the trip would be. If you were doing it in a Learjet, it would probably involve 5 to 6 fuel stops and would take 20 hours minimum. I would say a good 20 hours. So when you're circling the ocean that way, that's not very pleasant. Air ambulances are very cramped spaces. There's usually no lavatory. There are no meals served. You usually can't accommodate additional passengers, family, and it's not the way to travel for most people. So, in fact, what we usually find is we have already gotten that person's medical condition under control with a shorter evacuation, and that may well be by air ambulance. But then we're usually accompanying them with the appropriate medical staff and equipment that we can translate onto most commercial carriers. Commercial carriers, they vary in what they're willing to do, but many of them will take stretchers. In fact, Lufthansa has a unit they'll set up which is like a mini ICU, which will go between their main ports. So there's much you can do on a commercial carrier. Oftentimes that's only one leg, maybe two at most, and usually we get patients home expediently, sometimes faster than we can arrange an air ambulance by using those modalities as well. So no, it doesn't necessarily always involve an air ambulance or a medical helicopter.
Okay. Another question is about a reliable source of information on overseas hospitals, particularly hospitals that might serve trauma level emergencies.
Well, from my point of view, working in assistance is that one of the key tools that any good assistance company will provide, which they will rely on themselves, but will also provide for information to their clients, is a strong database of medical providers worldwide. And it will usually indicate preferred providers, which should be chosen based first on quality, but then, you know, financial arrangements, those providers that you know will accept your insurance or your coverage. And yes, that database should clearly indicate who has trauma capabilities versus cardiac capabilities. We have in our database that we call, our internal tool is called CTY, which stands for Close to You, and we make key information from that available to certain clients who wish it, for them to have an understanding of what specific specializations and specialties they can access in particular providers around the world. So in addition to consulting that source, the assistance provider is typically available to call, and they can give you more detailed information about the providers in their database, and that's what we do on a regular basis.
Okay. There's a couple of questions that kind of relate to each other. One is about how much information could be shared with an employer about an employee who gets sick when they're traveling, and that kind of relates to the other part of that question about, you know, what's the impact and how do you communicate out to your employee population when they return?
Ron, if you don't mind, I'll still field that one. This is a complex question, and it's a really good one, and important to have an understanding in advance, because most of us in the countries we function in are subject to strict medical confidentiality laws. And I think they're pretty similar in most of the regions we all work, which is that medical information is shared on a completely need-to-know basis only. So you only share medical information with generally those medical providers and, in the case of the U.S., insurance payers whose input is needed to make the right arrangements and to ensure the patient gets the level of care they need. Beyond that, you usually need the patient's permission to share their medical information with anyone else, and that typically includes the employer. As you all know, in your home situation, you generally you don't have direct access to your employee's medical information. And the same principle presumably applies when the patient gets sick abroad. So, however, the reality of the situation is that in order to make the right logistical and decisions, the right transportation decisions, it usually requires some input from the employer, and that complicates this situation. What we typically do is communicate first off with the patient as an assistance company, and we are dealing with the medical information as inherent to our work, and discuss that with the patient or whoever is legally empowered to speak for them, and say to them, look, in order to do what you need, we have to share or discuss some information with your employer. We will only discuss the things that are absolutely essential, but in order to arrange for the transportation you need or for the resources you need to manage your situation, and we generally get their permission to do that. It's rare that an employee doesn't understand that, but you have to go through the motions. You have to have it properly documented, whether it's audibly recorded or whether it's having them sign the appropriate paperwork. But I think employers need to be aware of these limitations, because oftentimes we have managers demanding information, and we're in this awkward position of, well, we're not sure that the employee has authorized us to disclose their sensitive medical information to you. So we do, as going back to what you asked about earlier, we make sure that's part of this communications organization that I said earlier was so important to clarify both before you get involved in these situations and once you have a case going active.
Okay. So here's another question that just came in. It says, during a medical emergency like the ones that you've discussed, level of involvement that you generally see from an embassy, and in what ways does their involvement either help or hurt the situation? So this may be for John too, as you know, these security situations come up.
John, what's your take?
Well, I can jump in. I mean, I'm sure I'm going to probably say the same thing as Kai. If you're relying on the embassy, you're in a world of hurt. The embassy does not have the capabilities in most areas to really assist with this. They can give you some basic information. They're not going to handle your medical situation. They're not going to handle the evacuation. And if this is during a high threat situation, such as a government overthrow, where you've got someone injured, but they're also in a security situation, the embassy's not going to be able to do anything for you because they're handling essential personnel movements. And it's not a good idea. And as Kai mentioned, usually when there's a real challenge, it's because it's a remote location. And again, there is no embassy or consulate to go to there. So if you think you're going to go to your country for support, that is an absolutely bad idea. And it probably needs to be completely removed from your company's protocols. Sure, registering with an embassy is fine, especially when you're going into a more hostile environment. There's nothing wrong with that, to let them know you're there. But if you're looking to them for help, that's just not the way it works. This isn't 1947 anymore, and the embassies just don't have the internal. It's not that they don't want to. They don't have the internal resources and capabilities to do that. Sure, if somebody showed up at the embassy door sick, they're going to try to get you to the embassy doctor to help them, but that can't even be guaranteed because it depends on the type of sickness you have, and they have limited medical capabilities. It's not like the embassy has a emergency room with a cardiac care unit.
Yeah, I would agree with John. I don't think you should count on putting too much dependency on the embassies. They can be helpful. We sometimes find them very helpful in generally less acute situations, and especially in some of the more remote situations, in advising us on the latest on who they like to use medically. Clearly, if it's a question of getting documents replaced, they're often needed, but they generally don't have any significant level of logistic support, and that includes medical logistic support that they will actually provide. I do find, though, that just the experience I've had with some of our clients, that those who take the trouble to establish relationships with the embassies and the consulates and stay in close touch often benefit from that ability to network with them early on, and working kind of in collaboration with them and the embassies. It can sometimes help very much. So I think it's useful to establish those relationships, but I wouldn't count on them for serious logistical support, as John says.
Okay, great. I see that we are running out of time, so I just want to close with some information about our upcoming webinar in April. We will be talking about security, terrorism, and unrest, and drivers for risk management competencies. I wanted to thank everybody for joining us today. If there are questions we didn't get to, you can certainly email those to IJET, to info@ijet.com, or to health@ijet.com. We will certainly pass those on to Dr. Glushak as well. Thank you, John. Thank you, Kai. And thank everybody for attending today.